Afternoon. Thanks everyone for being here. Welcome to Bioethics Grand Round, sponsored by the Center for Bioethics and Social Sciences in Medicine at the University of Michigan. We are honored to welcome one of our own to the stage. Dr. Lauren Smith is an associate professor in the Department of Pathology, but has a very broad background in medical ethics and medical ethics education. She's a product really from the beginning from the University of Michigan, undergraduate medical school, research, residency, and fellowship, and has been a member of our clinical ethics consultation service as well as ethics committees for many, many years, and has really been one of the most committed and hardest working members of our group. Her specific area of expertise is in hematopathology, and she's the fellowship director of the hematopathology program within her department, and also serves as the director of the ethics path of excellence within the medical school. And has really taken a leadership role in creating a dynamic co-curricular program in medical ethics within our new curriculum. Today, she will be speaking about an area that she is really renowned as one of, if not the expert in the country on, which is ethical issues in the allocation of blood products, both specifically as well as more broadly in terms of clinical pragmatic approaches, as well as more theoretical and practical approaches. So without further ado, it is my privilege to welcome Lauren to the stage. Dr. Smith.
Thanks, Andy. He's always good for morale boosting with his nice intros. So this is something that I became interested in. I'm actually a hematopathologist, so I don't work in the blood bank, but I became interested in this a number of years ago and wrote a paper about it for with some of the blood bank colleagues that I have. And I don't think they're here today because we actually have faculty meeting right now. So this was sort of a collaboration because of some cases we had also seen on the ethics committee. I don't have any disclosures. The objectives today are, it's going to be a review for those of you who have been to a lot of these ethics grand rounds, but understanding basic ethical principles that should be considered in health policy decisions, understanding issues involved in transfusion and blood product utilization, and especially at the end of life. That's been sort of the focus of the work that I've done on in this area. And then we're going to try to apply some ethical principles to cases involving transfusion of terminally ill patients. And I think the important thing to remember and why this is especially important is blood products are really a scarce resource. We don't have unlimited blood. When I was a resident, we would often have shortages of different types of products, and the residents would be sort of doing this, you know, case-by-case rationing on their own when we were on call, which I don't know that a lot of people understand is done. All right, so my background, as Andy said, I'm an academic hematopathologist. I've been on the ethics committee since 2005 when I was a fellow. I also am a member and chair of the Michigan State Medical Society Bioethics Committee. If anybody's interested in that organization, they can contact me. But again, I'm not an expert in transfusion medicine, so if there are any techs or actually blood bankers in the audience, I might be a little weak on the blood product side of things. So in terms of why I chose this topic, as I mentioned, blood products really are a scarce resource, and I think it's especially difficult in terminally ill patients in deciding how to allocate some of these products, especially the more rare types of things that we deal with. Many of you may not be aware that we do things like cross-matched platelets, HLA-matched platelets, things that are difficult to obtain and expensive. And then there's really no universal guidelines, and there aren't even a lot of hospital guidelines. So we have thought about developing some ourselves, although sometimes it's a little bit easier to attack a case on a case-by-case basis rather than trying to form guidelines that may not apply to specific situations. So at this point, we really haven't had any hospital guidelines on this. So in terms of ethics, for those of you who don't attend this often, there are definitely many different ways to conceptualize ethics and many different frameworks for clinical ethics, but I was going to talk about these cases in terms of the principalist approach by Beecham and Childress. So that's a common way to talk about these different ethical issues. So Autonomy, most of you can tell me that this is the basis of informed consent. It's really the idea that patients should be able to make their own medical decisions. So we like to have patients decide how they're going to be treated or what kinds of interventions they're going to undergo. And it was really, all of these principles were a bit of a reaction to paternalism and the idea that doctors knows best. In the 1950s, when my grandmother had cancer, nobody talked about it. Nobody told her what her options were. Nobody probably even really explained her diagnosis. So in the 1960s, things really changed when some of these ethical principles came about with the Belmont Report. So the other principles are beneficence, and this is really the idea that physicians should make recommendations in the best interest of their patients. And that seems sort of obvious, right? Like you should always do what's best for your patient. But sometimes people have ulterior motives or financial motives, and really the patient's benefit is the primary concern, is the idea here, and you should try to avoid competing interests. So I gave you my disclosures so you know that I don't have any competing interests about blood products. Non-maleficence is sort of the reverse, so physicians should not harm patients, and the patient's well-being is really the most important thing, and in that way it's somewhat similar to beneficence. And social justice is a more controversial principle, I would say. It's the idea that everybody should have access to the same types of care and access to care in general, which we don't even have necessarily in our society. We're getting closer, but we're really not at the point where everybody has equal access to every sort of treatment. But it's the idea that if you do have similar patients with similar circumstances, you would want to have them have similar opportunities. So that's a very important principle, I think, when we're talking about blood product allocation. Other considerations, always being honest in your interactions with patients, honoring promises, it's very important, and also flexibility. That's why we don't want to have too strict of guidelines, because we want to be able to look at a particular case and see what the nuances are, and then adjust our recommendations based on specific cases. Although we don't want to do bedside rationing, so that can be a challenge, because we don't want to have one attending come into the ICU and say, nobody's getting these blood products, and then the next attending come in the following week and say, everybody gets the blood products this week. So that's why it is better to have some policies that are flexible. Futility, we don't call it that anymore. We call it non-beneficial care, essentially, but it's the idea that medical care doesn't have to be provided if we think that it's futile. So different situations that this could apply to would even be everyday occurrences in the pediatric office about whether you're going to have antibiotics for a virus, so that would be futile care. So you wouldn't have to do that. But oftentimes we use this concept in end-of-life situations where we really think that any intervention is just postponing the moment of death, a ventilator and somebody dying of cancer, these sorts of things. There's really no laws about this, although Texas does have a law. We don't have any laws. But hospital policies often deal with this issue, and we recently revised our policy, and it's available to people to see on the website. So the idea is that the autonomy of the patient does not entail the right of the patient or the patient's representative to command treatment that is medically inappropriate. And this is actually sort of timely, because there is something in the legislature right now about requiring that patients or their families consent to not having treatment by a physician. So you could imagine that people might demand services that are not indicated based on the patient's medical state at that time. And so we're really hoping that this legislation is overturned, because you really should not be required to offer interventions to patients that are not considered beneficial and are not considered something that will advance their goals of care. All right, so you must satisfy certain conditions. So if we want to use the non-beneficial care policy, we have to say that an attending physician has determined that the patient's condition is terminal and incurable. The attending has determined that the intervention is not required for relieving patient's discomfort, and determined that the intervention offers no reasonable medical benefit and could only postpone the moment of death. And then we also have another physician who will come in. It should be an independent physician who agrees and isn't part of the team, so really as independent as possible, that agrees with this medical situation. And there's always the opportunity to transfer a patient. So if we decide that we don't want to offer something or we want to withdraw care because it's non-beneficial under this policy, we always give patients and their families a certain amount of time. I think it's at least 72 hours to transfer the patient to another institution. Unfortunately, like a lot of institutions don't want these patients. They're very expensive, and end-of-life care is difficult that way. I think the only time we've had somebody actually get transferred that I remember is when it involves dialysis, because of the laws around dialysis, that's really well reimbursed. But otherwise, it's difficult because often these patients don't have other hospitals that are willing to care for them. And then the hospital ethics committee is consulted. So usually in these cases, they'll call ethics, and we're available 24/7 for consult calls, and some of our consults involve this futility idea. All right, so does anybody have any background questions before we do some cases? Okay. So Ms. T is a 54-year-old woman with metastatic cancer diagnosed 3 years ago. The tumor has now invaded her bowel, and she presents with intractable bleeding. Surgery and radiology are consulted, but there is no treatment that will stop the bleeding. And currently, she is requiring 5 units of packed red cells per day. And they anticipate that this will continue throughout the rest of her short life. The physician speaks with the patient, and she wants to do anything and everything to prolong her life. And she specifically says, "I'm not ready to give up." So her family is in agreement and wishes to proceed with the blood transfusions. So this was an ethics consult we had maybe like 5 years ago. So just some background for those of you who don't do transfusion medicine. This data is a couple years old, but about 17.3 million units are collected each year. And we definitely have shortages. Around like Christmas time, it always seems like we have like O-negative shortages. And certain blood types, we always have like lower stocks than others. And it's easy to forget that really a blood transfusion isn't just a drug or an intervention. It's actually a person has to go and donate. We don't have blood product substitutes in use yet, I mean, although they're being developed. So it really is something where when we get short on blood products, it's usually around the holidays, we have to have a lot of blood drives to get our inventories back up. And so I think we have to think about this intervention that way, because it's really something that is special because it comes from a person, I think, and somebody donated this intervention. So what do you guys think? Do you think she should get the daily blood transfusions? And I require audience participation. I mean, it's sort of hard. I think this is a hard one. What did I say about like bedside rationing? So we don't like to say like, today you can have the 5 units of blood because there's no policy, but tomorrow you can't. How many people think she should get the transfusions? Nobody. A couple people. Who thinks she shouldn't get them? Should not. So yeah, so a lot of people don't like the idea of using all these blood products. And actually, like physiologically, it would be difficult to continue to transfuse somebody this much blood every day. So if we look at the analysis in terms of the principles we talked about. In terms of autonomy, it's very clear. The patient wants the blood products, right? Her family wants the blood products. She still has decision-making capacity to say that she wants the blood products. In terms of beneficence, they will benefit the patient if, by benefit, we mean prolonging death, like time alive. So if her goal of care is just to live like half a day longer, then that does meet her goals of care. But if her goals of care are to go home and garden and not be in the hospital, it does not meet her goals of care. So we have to think about it that way, I think. Non-maleficence, probably unlikely to harm the patient, although if you did have lots of transfusions long-term and you weren't dying, you could develop antibodies, volume overload, like other issues that would sort of preclude you being able to get this many products. And it may prolong her suffering, right? If she's suffering from her cancer, this may actually prolong her suffering, although we do have good pain medications now, obviously. In terms of social justice, I think it's harder. As I mentioned, red blood cells are a scarce resource. If she receives them, somebody else may not. I mean, that's sort of not really true necessarily for packed red cells. It can definitely be true for platelets. And we really can run short, and usually we don't completely run out. But I think we need to think about them that way. But then again, like in our society, we don't like the idea of rationing. We don't like the idea of what they have in Britain where things are decided, we're gonna pay for this, we're not gonna pay for this, we're gonna do this, we're not gonna do this. We like the idea that everybody can get everything that they want, especially if they're willing to pay for it. And we really do though, like our residents are rationing every day. They're like, well, you know, there's only, we don't have very many platelets, so we do sort of ration. We'll say like, well, you know, if the platelet count's 30,000, she doesn't need those platelets, and we will say no sometimes. So is it fair? Is it fair to use this kind of rationing, which is like more of a first come, first serve kind of rationing, or should we have other ways of doing this? Similar situations in ethics would be transplants, so organs are even more scarce than blood products, right? And we have very strict rules about who is where on those lists that really we do not influence on our internal ethics committees. These are set statewide and often nationally, so really we don't participate in that, but you can sort of think about it a little bit in a similar way in terms of it being like a more scarce resource, but still a scarce resource. So other situations, we've had to deal with the possibility of flu pandemics. Andy Barnosky was on a committee to decide who would be the priority person for a respirator if we didn't have enough for everyone a number of years ago when he was the chair of the ethics committee. So there are other situations and things like ECMO where it actually is a similar situation where we might have scarce resources. Another one would be smallpox epidemic, where we don't really have enough medications anymore because we don't really have vaccine doses for everybody in our society. So things like the military would get priority, and like probably some healthcare providers, things like this. ECMO is probably familiar to many of you, and ECMO actually uses more blood products probably than anything I'm going to talk about today, so it's probably its own topic. ICU beds and hospital beds, even just a regular bed on the floor can be a scarce resource if we have a bed shortage, which often does happen. So ways that you could approach a case like this, I think would be to have a conversation with the patient and the family to clarify the goals of care. So as I said before, if her goal is just to live like another day, then sure, this might meet her goal. But if she thinks that she's gonna make it home and she's going to spend quality time with her family, or she wants to die at home, this really doesn't satisfy that goal of care. And is she waiting for something? So sometimes we'll allow more extreme measures if we're waiting for some event. So sometimes we don't disconnect a respirator until somebody's loved one arrives from out of town. You know, we think that that's okay to have a couple more days in the ICU, even if it's expensive to allow that sort of occurrence. So we could talk about all of these things with the patient and the family. And then I don't think you want to coerce people at the end of life, but patients often don't understand when things are scarce or when we might have difficulty in these types of situations. So sometimes just discussing the fact that the blood products are scarce with the patient can be helpful. And that's actually what we did with this patient. We said, it doesn't seem really feasible that these blood transfusions could continue at this rate indefinitely. We tried to clarify the goals of care, and actually the family was fine with not transfusing the patient that often. You could try to set limits, although I think if we're going to do that kind of thing, we need to have better policies. So we would probably need to have some sort of institutional or national policy that would support us on that. Because there's a lot of situations where many, many units are used in nearly fetal situations, which we'll also talk about. So any questions about that case? I mean, interestingly, the resolution of this case was that they said, there's nothing we can do. She's just going to keep bleeding. We can't do anything. And then the bleeding actually slowed down, and she was able to transfer to hospice, and I think she was only getting like a couple of units a week or something when she left. Yep.
So as a non-clinician's question, maybe obvious to you. So why in our patients typically ask about whether or not they want to have continued transfusions, right? If this patient, for example, is determined to be terminally ill, then I guess I'm not sure, like, why was this offered to them as a decision versus the clinician making the decision versus?
I think the reason that this was asked of the patient was because of the sheer number of units that it was going to be taking. Because if somebody's in the hospital getting transfused every few days, I don't think anybody thinks much about it.
Decision, not a doctor's decision?
Well, so it could be. Like, the doctor could say, based on the futility policy, that's not indicated, and say, now it's time.
There's variability.
Yeah, you could. It's a little easier with things like dialysis, I think, because you just don't offer it. If it's not going to benefit somebody at the end of their life, don't offer it. The problem that I think we get into sometimes, and the reason we get a lot of consults at the end of life, is because we like to give people this menu of options of things they can have or not have. And it gets really complicated because you don't want to have people checking off chest compressions and not checking off ventilator and
I guess that's what this feels like a little bit.
Yeah, I think I don't know. I mean, it's hard because it's hard because it would be pretty quick if she really was needing that much, she would probably die in 24 hours. But yeah, I think you could question why the clinicians even considered it.
Is that typical? I guess that's sort of what I was. Is this typical in this?
Yeah. I mean, and we'll talk about even more egregious sort of situations.
Well, there's not an ethical difference to not offering versus stopping the transfusions. It feels very different. It could be bleeding. You might have started them and then figured out later there's nothing you can do to stop the bleeding, source of the bleeding, right? So they'd already been asked, and then having the conversation about stopping them and the implication, I think, for that family to know that it will be hours or a day when the life we stop them now. I think even if it was our decision to make, trying to help them and figure out how to support them through that would be challenging.
Yeah, because it would be sort of fast and acute. All right. So case number 2 is a 20-year-old woman who was injured in a head-on collision. She's brought by helicopter to the trauma center, and her injuries are not survivable. The trauma surgeon requests 20 units of blood to keep her alive until her parents can arrive to say goodbye. They live 3 hours away by car. All right, so the patient obviously is unable to discuss this with the surgeon. So the patient is unresponsive, in a trauma situation and will not be able to consent. So in those sorts of cases, we defer to, in emergency situations, we just do best interest standard. But if we had time, we would, figure out who her decision maker was if we were doing some other sort of procedure. So we pretty much do a presumed consent in these sorts of situations. I remember in July, this is like an aside, but one time in July, I got a page when I was on the ethics consult service from an ER intern who said, "We're trying to resuscitate this patient, but we can't contact his family members. What should we do?" And I was like, go, 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 keep going. You know, you don't want to, when anybody's in like an urgent care situation, you don't want to wait to get consent from someone. But the question here is like, is this a good reason to send those blood products? Like, let's talk about that. All right, so the patient supposedly has no hope for survival. So it's not like, you know, a lot of times we use lots of units on patients. She's young, right? Like if we could get her to survive, we could pour units into her and it would be worth it, right? She's 20. She'd probably have every sort of priority on any sort of pandemic respirator list because she's 20. So she's like a young adult, well-formed personhood, you know, has a huge long life in front of her. So we tend to prioritize those sorts of people for different interventions in scarce product utilization. The goals of care are clear, but the patient hasn't agreed to this goal for resuscitation until her parents came. And is it reasonable? Is it a reasonable thing to request of the blood bank to do this? So we often have massive transfusions. We're a center that gets a lot of car accidents and things like this, and sometimes they happen in other sorts of situations as well. And, you know, if it's reasonable to do this completely, if the physician thinks that a life can be saved. However, we know in this case that this patient will die. So in terms of autonomy, the patient can't consent, but, you know, we don't need consent when we're transfusing people after a car accident. In terms of beneficence, it's not going to benefit the patient. In terms of non-maleficence, it probably won't harm the patient either because the patient's going to die. But in terms of social justice, what could we do with this blood? Like what other sorts of clinical scenarios could we use this blood in? All right, so what do you guys think? Is it a reasonable thing? I mean, it's like I said, you know, we're just waiting for something to happen, right? Like we're waiting for the parents to show up. Yeah.
Is there an ethical consideration about the value of the parents being there with her when she died?
Yeah, is there? Yeah, I mean, I think that would be the reason that the surgeon wants to do it. Do you think she'll have any sort of cognition that that's happening at that point? I mean, I think like that would be the argument would be, well, you want her parents to see her before she dies and then she could have somebody with her. But, you know, I really think that this sort of goes above and beyond like what we should allow. It's one thing to try to do everything to save someone, and it's another thing to say that we should do this to have somebody's parents have time to arrive. And actually, it's probably sort of unrealistic in some ways anyway. And it's not necessarily going to be comforting to the family to be watching her get resuscitated when they arrive. So I would say that this is too much, and that might be sort of controversial, but I think it's too much to ask.
So I think one challenge of any rationing schema is the fluctuating supply, and I think blood products are a perfect example of that dilemma. So I guess the rhetorical question I'll put out there is this calculation in any way influenced by what blood type she is and what the existing hospital supply of that blood is? And obviously that brings up the issue of the only way to deal with that is in a bedside rationing schema, but perhaps that is the most effective way of balancing the competing interests here.
Yeah, so I mean, if we had like, so Andy's question was, does it have anything to do with like what her blood type is or what kind of stores we have at that time? Like, is it November or December, we have shortages, or is it like January and we have tons of blood? I think that the problem with like using that as a metric for making the decision is that it sort of sets a precedent. So then somebody's like, well, they come in November and they sort of expect the same treatment. So I think we could use that, and sometimes we do. Like sometimes we just don't have enough products, but we usually have like enough O-neg to like get somebody through a massive transfusion. I guess my colleague, who's a blood banker, is here. You can tell me if that's true.
So we generally tend to rely on to make the decision of whether the massive transfusion decision is medically warranted. And then we try our best to meet that order and to provide blood, be it calling the Red Cross at all hours of the day, calling other hospitals, funneling blood from the region, basically, and down from Ohio. So once that order, the decision's made, we try to honor that.
And so you usually can find it, but it could take a lot of depletion of other centers too,
Right,
theoretically.
because there is a continuing regional and national blood shortage. So it'll take time. It does end up depleting the region.
Yeah, so I think like if this was a slightly different case where they still hope they could save her, that would be different. But in this case, I don't think it's the right thing to do. So I'm going to say that, even though, I don't know. You could argue some of that, but I'm not 100% sure it's going to help her parents to be there at that time. And who knows if they'd even be able to make it that far. Any questions or other? Yep. Patricia.
I just want to point out that medical interventions are not the only things that can be used to help parents in these situations. I agree, working with blood is a lot to try and know the work. And the intention is to help the parents in this dreadful crisis and tragedy. We have wonderful chaplains in this hospital, for example, who could be called on to be there and help the parents deal with finding that their daughter has died.
Yeah, and I think Patricia's right. So she's talking about how we have chaplains that can be supportive. Sometimes we even have like visitations in the morgue for families. And I think those sorts of interventions are probably equally beneficial to having somebody have to go into the trauma center and watch a resuscitation. So I think that's a good point. We do have a lot of things for people like that at the end of life that don't just involve like, you know, seeing the patient in that situation.
Was the blood provided in this case?
You know, this was a little bit more of a theoretical case based on things that have definitely happened in the blood bank, but this wasn't an ethics consult case. So this was something that Laura Cooling, one of my colleagues, had happen in the blood bank. And I think in that case, I think it was provided. Like, 'cause as Sean said, like we don't do like rationing in the blood bank, so. All right, so Tina is a 5-year-old girl with acute lymphoblastic leukemia, and she has failed numerous chemotherapy protocols, and recently her family decided to make her comfort care. She developed a nosebleed, and the resident calls the blood bank requesting cross-match platelets. And this case actually happened to me not when on the ethics committee, when I was a resident. So the blood bank contacts me to discuss this request with the pediatrician. I think it was like it might have been a resident that I was talking to. So I explained that cross-match platelets should not be used in this clinical situation as they are difficult to obtain and, you know, even more scarce than regular packs of platelets. And the pediatrician is completely incredulous and says, "How can you deny this to this dying child?" It's very dramatic. All right, so cross-match platelets, we have 2 million apheresis equivalent units of platelets collected in the US per year, and cross-matched HLA matched platelets are especially difficult to obtain. So we use these in situations where patients aren't responding normally to your average 5-pack of platelets, which are also scarce. So do you think the patient should get the cross-matched platelets? How can you deny the dying child? Are you heartless? Are you a heartless pathology resident who never sees patients? Yes.
I guess I'll ask the medical question, is there a compromise? And in the case of someone dying, is there really a need for them to be able to match?
Yeah, or cross-match, no. Yeah, so is there a way to have a compromise? And like, could we just try some like regular old platelets? Yes, that could completely work in this situation, and as could other interventions, like for my clinical colleagues out there, like what might be the first thing you try when somebody's having a nosebleed? Packing the nose. So these sorts of things are definitely preferable. So in terms of autonomy, obviously the patient's family has not consented to the transfusion necessarily. It's just something that the clinical team is requesting. or the patient's family would have sort of inherently consented to this because they consent for the patient because she's a pediatrics patient. In terms of beneficence, the patient may benefit, theoretically, I guess, in that the nosebleed might stop, but other interventions, like we mentioned, like packing or regular platelets might be completely sufficient. In terms of non-maleficence, the patient could have a reaction to the transfusion, so this does happen, and so it's not necessarily a benign occurrence to give somebody a transfusion, because we get called all the time about transfusion reactions. Probably less commonly in this situation, but. In terms of social justice, other patients could definitely need cross-match. Other patients could need these platelets. And the donor risk is bigger because they have to all be collected from the same person, and they have to get frequent donations. And so I don't think we should discount the fact that there's a donor risk to giving these sorts of products as well. You can, when you give products, you can get an infection, or you can have problems with your vasculature. And then there's the financial cost to our healthcare system as well, which we try not to factor in too much, but it is more expensive and more difficult to obtain. In terms of risks to patients about blood transfusions, a lot of people don't realize that there's a risk of infection. Transfusion reactions are pretty common. Trolley is a very severe form of transfusion reaction that leads to life-threatening lung injury. And then you can also develop alloantibodies, so this could make it very difficult for you to have transfusions in the future if you're not an end-of-life patient. So it's not really like getting a transfusion is completely without harms, right? We know that a lot of people in our society have hepatitis C and HIV because we didn't know about that when we were transfusing them a long time ago. So in terms of resolution, we suggested that they attempt to control the bleeding with packing and local hemostatic measures. If the bleeding was causing distress and prolonged, consider a standard pooled dose of platelets. And then we didn't actually find out what happened with this particular patient, but it seemed that they were satisfied with that. Any questions or comments about that?
So how often do you get into discussion about other medical interventions that the team should or could?
In ethics, I don't, but I was a pathology resident, so I don't know if I told them to pack the nose. That would probably insult them, but I think it's perfectly reasonable to suggest other options, especially when you're a medical doctor consulting on a medical case. In ethics, we might make recommendations, but we don't typically focus on the medical. So we don't usually say, I can't believe that you're doing dialysis 3 times a week. We don't focus on that kind of stuff in ethics, but because we try to let the team focus on the medical care and we focus more on the goals of care, but this was a little different because it was more in the context of medical care.
This was interesting too, because I thought you said that the parents had decided on comfort care. So
Yeah.
That's interesting that to me that says the goals of care would not, this might not be aligned with people.
Yeah, so so we'll talk about that next, I think, whether you can have transfusions in the setting of comfort care, and you can. You can definitely have transfusions, but they should probably not be really unusual things or very extensive things. So I'll talk about what I think is reasonable in the setting of comfort care. All right, any other comments about this one? All right, Mr. M is a 70-year-old man with end-stage colon cancer. He's undergoing palliative radiation. He visits an oncologist, and a CBC shows that he has a low hemoglobin. Upon questioning, the patient states that his fatigue has gotten worse in recent weeks, and his oncologist would like to transfuse him with 2 units. It's funny because when I give this talk to blood bankers, they're like, why can't they just start with 1 and see if it bumps? And then, so we're going to say they asked for 2. So do you guys think the patient should receive the transfusion? The patient's living at home, participating in most of his, daily activities normally. and, feeling sort of tired. Yes, so who wants to give him the transfusion? Yay! All right. So transfusion is palliation for fatigue in this situation, especially with a hemoglobin of 7. Like if his hemoglobin was 11, we could talk about that. But this type of order should be encouraged if clinically indicated. And I think what this sort of combats, this particular case, is the idea that when you have elected palliative or comfort care only, that you aren't abandoned. Like we don't say like you can't have antibiotics if you have an infection. We don't say that you can't have other things that could improve your quality of life while you might not do chest compressions. You can still have things that will make your daily life better. And transfusion can be really important in this context. And I think it really is important, partially why we shouldn't have really strict guidelines, because on a case-by-case basis, we can decide if this is really indicated. All right, any questions or comments about that one? I know, it was the easiest one. But like people, like when I wrote this up, I think I needed to have like something that is really indicated, because blood products are very important in patients, especially even at the end of life. So it's not like you want to be completely dogmatic and like no more blood transfusions. So in terms of additional studies, I had a student working on this at one point, but he did graduate. So if anybody else wants to work on this, we can do that. To survey hospitals regarding end-of-life guidelines and transfusion guidelines, and maybe even do more of a public opinion sort of assessment of this as well, sort of seeing how the public feels about these sorts of questions. And then trying to establish some best practice guidelines. I really want to work on a policy, but I'm a little bit nervous about working on a policy because I think policies can seem too strict. So I think I probably should continue to try to write some sort of policy, because other hospitals are very interested in this. Like I get lots of questions about whether I've written this policy and if they can have it. All right, any other last minute discussion items? Yeah.
Maybe beyond the scope, but I think non-transfusion is the other side of this, and being asked to get a patient through something that would routinely require blood to do safely.
Yeah, the Jehovah's Witness stuff. Yeah, that's a great point. So I probably should put something in here about that. So the question is about not transfusing patients when you normally would. So there are some surgeries where you probably wouldn't feel super comfortable going in if you knew you couldn't transfuse the patient. And there's actually a really interesting paper, and I don't have the reference with me right now, but it talks about how Jehovah's Witnesses patients tend to do like sometimes even better than their colleagues getting surgery, because the blood products just aren't helping people as much as we think they do. And giving them like IV fluids and things can often get them through it. And that you don't have the same risk of like sort of adverse reactions to blood products. So I thought it was really interesting, because I just figured that they wouldn't do better, but that they actually have pretty similar outcomes with big surgeries. I don't know if that was sort of a biased study, but it seemed reasonable when they analyze the data, because we have a very big Jehovah's Witness population here, so that comes up often in ethics. And when we deal with it, as long as it's an adult, we honor their wishes. If it's a child, we don't. So children, we would not allow them to not receive a blood transfusion if they needed one. And interestingly, the families don't seem to mind, because it's sort of like, you made the decision, the weight of the world is now off of us, we don't have to suffer for this decision, and we don't have to be responsible for this decision. So it's not quite as contentious as I think I thought it would be. Yep.
This is a really interesting topic, and thank you for doing it.
Thanks.
But I guess I want to point out that this is a very American talk.
Mm-hmm.
If you gave this talk in Canada, people would not understand what you were talking about. And I spent a lot of time going from countries where at any given time, University Hospital data that they have 2 units of blood bank, 80 blood alcohol.
Yeah.
And so a lot of this discussion about rationing, a lot of this discussion about decision making, and really blood is just kind of one of the technologies that we work with people in the United States. It happens to come from other humans, but people who come from low-income countries and listen to us have these discussions don't understand
I know, they think we have so many resources, right?
And so, I think, the comments about rationing, that we don't do rationing in the United States, really kind of back to the point, we need to start thinking, we obviously thinking about these issues here. But, a unit where on any given day, 6 or 8 women be dying of childbirth because there's no blood, people have a very different view of these things. So I think it's a really important talk. Even if you go to Canada, they do talk about rationing, they do talk about resources. This is just one thing
Yeah,
we need to kind of face.
it's definitely true.
Africans, which I can look down and care, they have no access to narcotics. And so, how you make people comfortable, how you deal with death is a really different than how we do here. It's like, the underlying theme is how do we deal with death? And I think that we deal with it on this, but I think we're trying to do that. But I guess that would be my 2 cents, as I sat there thinking
Yeah,
that people would just think this is fancy.
I know, it's like an embarrassment of riches. I mean, it is, and you're right, like in other countries, they don't have access to any of these things, so that would seem like ludicrous to give somebody all these units of blood for something that's not going to really help them. And I think we do. I'm all for having something like the British system where we decide which chemotherapy drugs are going to be offered that year and which are just not available, because they don't extend your life more than 3 days, on average. So I definitely think we need stuff like that, because a lot of our ethics consults are from patients who don't understand the dying process or death and like the sequela and like what's really happening. So I think we do need a better understanding. I feel like maybe I've become sort of jaded over the years in ethics, because now like all I think about is death, and like you just sort of don't want to think about that so much. But there's a lot of lay people out there that don't think about it ever, and so when they come here and their relatives on a ventilator, they don't understand like how this is going to end. So I think that's totally true, and like this really doesn't have a lot of international relevance, because we just have so much in our country, and we should probably be sending those 20 units over to Africa, right? All right, well, thanks for coming.